and welcome to Willow Lifeline Dialogues Code of Life series, where we dive into that conversation about science shaping family health. I'm your host, Dr. Mercy Korir, and today we are looking at something that may affect your child. Imagine if they suddenly lost strength in their legs. In the assembly line in school, they fall down, they struggle to walk, and you are facing many hospital visits that offer no answers. This was Shannon's life, caught in the grip of a rare autoimmune disease called polymyositis. Polymyositis causes the immune system to attack muscles, leading to weakness, fatigue, and sometimes even organ involvement. It is often misunderstood and a difficult diagnosis to make, leaving many families in months or even years of uncertainty. Here is Shannon's story.
Shannon's story began with pain, weakness, and endless hospital visits. Her mother, Saetwa Saitoti, searched desperately for answers only to be told it was stress, infection, or even hysteria. But what seemed ordinary was far more rare: polymyositis, an autoimmune disease attacking from within. That diagnosis would take Saetwa and her daughter from hospital wards in Kenya to alternative treatments in India through psychological strain, financial hardship, and moments of near hopelessness. Yet, out of that journey came strength, resilience, and a mother's determination to rebuild her life and give hope to others. It began with weakness, unexplained pain, numbness of the legs, and repeated hospital visits. Doctors suspected everything from psychological stress to common infections. But what she was facing was far more complex. An autoimmune disease known as polymyositis, a condition that attacks muscles and sometimes vital organs.
It's actually an inflammation of the muscles where it affects the hands and the legs. Someone is not able to stand from a seated position. They're not able to climb upstairs or an elevated position. They're not able to do so much for themselves, even go to the washroom. Then they can't also hold any object. Like even for Shannon, she couldn't hold a mug.
For months, Saetwa Saitoti and her daughter Shannon Saina went from one doctor to another. Each consultation raised hope, only to leave them with more questions, more bills, and no clear solutions.
Like 3/4 of the doctors we saw, their aim was to just push for the financial bit of it. Because I was seeing some of these doctors like once, twice. In fact, there's a doctor I forgot. I went to see her. She was so dismissal. The first thing she sees Shannon's training, she's like, I've seen this so many times. I know this. This is psychological. She can't be having any issue.
The suggestion that Shannon's pain was all in her head cut deep. For Saetwa, it felt like the system was failing her.
So at this point, I'm like, are this even working? You know, I was feeling like they're all doing guesswork. I was so stressed.
But amid the confusion and dismissal, there were rare voices of honesty.
But I found, out of all those doctors, there are 2 doctors I saw that were so nice, very nice. Then they said they don't know. They said, I can't help you here, Mama. There's definitely something wrong with your kid, and I'm sorry, I don't know what it is. You just have to get another opinion.
Polymyositis is rare. It often overlaps with lupus and other autoimmune diseases, all of them driven by a genetic misfiring of the immune system. For her family, the genetic link was personal, a reminder that this condition sometimes runs silently across generations.
And it's also confused with other autoimmune diseases. Remember, I told you polymyositis is a mother of lupus. Someone with lupus could be having polymyositis as well. So lupus is like the baby. Polymyositis is the mother. We may never know what causes them. It could be genetic. I could be having part of the polymyositis, I don't know. It could be the dad, I don't know. It could be from our family, we don't know. It could come from medication, maybe diet.
It was a friend who first suggested seeking help from doctors in India. For Saetwa, this lifeline came just after she had been told to accept that her daughter might never walk again.
You have to accept the fact that your daughter may never have walk again. You have to accept that. And they refused to write me a letter. That letter was supposed to help me push SHA to pay for my international treatment. So I didn't have a choice. I just went with half the amount.
In search of hope, she flew to India, a journey made possible only after several fundraisers. It drained the family financially, but she says it transformed their treatment path. There, the doctors confirmed an autoimmune disorder and began a treatment plan that relied less on heavy steroids and more on supplements, therapy, and tailored interventions. Slowly, Saetwa watched her daughter regain strength.
They took blood work the first time we got there. Within 3 days, they had the diagnosis. They were like, your daughter has something called polymyositis. Polymyositis is an inflammation of the muscles. That's why she's not able to pick something with her hand. She's not able to walk. She's not able to climb upstairs. She needs support and all that pain, because any muscle issue normally becomes worse, especially when there is weather changes, especially cold, sometimes very hot.
The care plan included muscle stimulation, oxygen and water therapies, light therapy, and intensive physiotherapy designed to wake up the brain and rebuild her muscles. The first few weeks were filled with pain attacks, and sleepless nights. Both mother and daughter struggled with fear and exhaustion. Yet, Saetwa pressed on, fueled by prayers, online fundraisers, and the unwavering support of her church and friends back home. Then came the turning point. After weeks of treatment, Shannon took her first steps again on her mother's birthday.
We have these housekeepers that help with that, or porters that help the patients. So they came with a nurse. So they didn't have the wheelchair. The housekeeper knocked. She's like, Mama, I have a surprise for you. Then turning back, I'm like, oh my God, Shannon is walking. I was so happy. I cried. Then after that, kidogo, the hospital surprises me with a cake. Oh my God, sinililia.
Along the way, Shannon discovered a new passion, drawing. Sketching became her therapy, a way to cope with the endless IV lines and long hospital hours. Saetwa too found healing in movement, joining evening Zumba classes with other patients and caregivers. Together, they embraced small victories even as financial struggles forced them to keep raising funds online for every phase of treatment. But for the first time in years, the pain was easing and the future seemed brighter.
And during this whole time, she had started drawing on her own. She got passion. Like that was her coping mechanism. Alikuwa tu akiwa IV haijaekwa vibaya ama haiko on the right, she draws. She started drawing and she became very good at it. She made friends. We made friends with patients in the hospital. Yani it was nice. Things were looking up. I was happy. I also started going to the physio, doing exercises. I even formed a team. We were doing Zumba with them in the evening to keep myself also calm.
Today, she is calmer, more reflective, and spiritually rooted. She mentors boys at a rehab, many of them orphans or survivors of abuse. She counsels hope, often for free. And she has found a renewed calling in her church.
I also do mentoring for boys. This is something else that has helped me. I have this rehab I go to and do mentoring. This I do voluntarily. I talk to them about anything and everything. These are boys who maybe were left by the parents. Some are orphans. Some have gone through drug abuse. Some were abused sexually. You know, it's so much traumatic things. So it helps me when I'm talking to them. I'm also counseling people for free. I have a counseling certificate, by the way. I need to be charging. But I do counseling. I have a few people who come to me for counseling.
She found a new purpose. She formed the Autoimmune Diseases Support Group Kenya after realizing just how many people were affected but left without answers. Some lived with symptoms without knowing it was autoimmune. Others had a diagnosis but no access to the right treatment. Her constant research kept uncovering new insights, though she admits she is still learning.
I formed a group called Autoimmune Diseases Support Group Kenya because one, I realize so many people have autoimmune and they don't know about it. Two, some know they have it, they were diagnosed by it, but they don't have the right treatment. Remember, I've been doing a lot of research about autoimmune. Every day I think I'm always finding out something new about autoimmune. I am not saying I know everything, I'm still learning. And through joining groups like Rare Diseases of Kenya, I found out about so many rare diseases. It's not even autoimmune, there are others which are rare that you've never heard of.
For families living with rare conditions like polymyositis, the journey is never easy. But stories like Shannon's remind us that with awareness, support, and resilience, healing is possible. For Code of Life, I am Sarah Kamande.
And to help us make sense of it all is Dr. Catherine Mutinda, a pediatrician and geneticist who works closely with families across Kenya to understand inherited conditions, children's developmental challenges, and the tough choices that sometimes come with knowing more about our genes. Karibu sana daktari, it's always a pleasure having you here with us.
Thank you for having me.
Now, we have just seen and heard Shannon's story of polymyositis, which is, a term or even a condition that is sort of unfamiliar or it can be unfamiliar to families and even some of the people watching us. Mm-hmm. What exactly is polymyositis and how does it affect the body?
So I'll break down the name so that it can be a bit more easy to understand. Poly is many. Myo, muscles. Itis, inflammation. So very many muscles that are inflamed throughout the body. So that is the name. It's actually a descriptive name for the disorder. So what happens in this disorder is that all the muscles are actually being attacked by the child's or the person's immune system. So they are being broken down. So they end up having muscle ache, muscle pain, and also because there's breakdown, so we say there's lysis, which comes like rhabdomyolysis. There's a lot of that lysis or the products of lysis that goes into the different organs, the kidneys, the liver. Because of all this, then you have this complex disorder that mimics a lot of other disorders. Mm-hmm. So as you said rightfully, might be very hard to come up with that diagnosis very easily. Mm-hmm. And because it's a big mimicker, like for example, what you talked about Shannon, she was falling. She presented as falling. But if you talk to her, she will tell you she started with stiffness. The muscles were stiff. So that fall, someone would say, okay, number one, those are the nerves. Could be that they are losing their nerves. So someone would want to check with a neurologist. Nobody is going to think about the muscle be the problem in a child who is really well developed. Mm-hmm. The next thing you'd think about is, okay, this patient is having inflammation, but nothing is pointing towards what kind of inflammation. So let me just take a step back and ask for myself and mm-hmm. answer myself, what really causes this? Mm-hmm. So the immune system is supposed to know itself and protect itself and know the external and fight the external. However, our immune system is taught this. It's taught this in childhood through the thymus. The T cells are taught in the thymus. And once they are taught, they keep on activating the B cells. So let's say you get a flu. The T cells present this antibody to the immune system, and the immune system starts fighting against that specific one. However, some viruses have some components that are similar to the muscle components of our bodies. So the body starts attacking the virus, and long after the virus is all cleared, the immune system is still fighting other components of the muscle that are similar to the virus it was fighting.
Okay.
Yes.
And such a condition, you've talked about, it looks like others, the mimicry. It causes inflammation. Is this why it can overlap or look like, other autoimmune conditions like lupus?
Yes, it can look like lupus, it can look like juvenile arthritis, especially when the patient starts complaining heavily around the joints. It may take people to think about infectious diseases like polio. People might think, oh, you're losing your power there. So yeah, it's a great mimicker.
Why is it difficult to diagnose?
Because it has no specific way of saying, I have a fever, you test, you find a parasite, then you know what it is. So you have lab tests that are showing so many other things. Then, for example, due to the lysis or the breakdown of the muscles, then the liver enzymes are rising. But they are rising in such a manner to think that the liver is affected by a hepatitis. But when you check for the hepatitis, it's not there. Then because of this, the clearance in the kidneys is also, the kidneys are being challenged. You go ask the kidney, is there anything wrong with you? No, nothing is wrong with me. And then now you say, okay, inflammatory markers, all of them are up there. You go and ask for infectious disorders. No parasite, no virus, no bacteria. So you're left, like a diagnosis of exclusion. You have to have a very high index of suspicion so that you can bring everything together into one consolidated diagnosis.
So how would this high index of suspicion come about? Because like for Shannon, it's just random.
It's very random.
So how do you then have that high index of suspicion to be able to make a diagnosis?
So one of the main areas I really advocate for is sticking to one care provider. So if we stick to one care provider, let's take Shannon, I think is 15. So there must have been a pediatrician who knew her for a long time, so that I know maybe Mercy is a child who is very averse to pain, who I have seen only for tonsillitis. This child is never actually sick. Then suddenly she shows up and she can't walk. So I'm not going to say Mercy is pretending, because I've known her for her whole life. So I will get serious about her diagnostics. I'll be like, she can't be faking it or something. Yeah. So that is one way. You stick to one care provider and follow through. Yeah. Number two, we are not all the same. So I'm a geneticist and a pediatrician, but a case like this, I would heavily rely on my neurology counterparts and my rheumatology counterparts. So I said they can mimic juvenile arthritis, they can mimic the lupus, they can mimic itself, polymyositis, and the muscles and the nerves are involved. So I would send them to these people. And then you go and everybody has, in diagnosis, you grow from the back. Yeah. You grow and tell the story. And then once all the dots are linked together, then you are able to say, there's an inflammation. I saw the inflammation. I saw the symptoms. The neurologists checked on the nerves and said the nerves were not culpable. I went to the infectious diseases specialist. They said there are no pathogens, so she's out. And then now we are with the rheumatologist. And then the rheumatologist tells you, yeah, this is the muscles, they are behaving like this. And then they put it together. And they say, okay, it looks like this, therefore this is the management that we are going to give this child.
So a multidisciplinary approach, not an individual, trying to figure all this out.
Yes.
Is it different in children compared to adults in how it presents?
No, it's not different. The only difference there is the time of onset. Because it's not there's no one gene that is responsible. It's multiple genes. So there's a high risk in some families of developing polymyositis, and other families who cannot develop it. So different. So that's why we have these genome-wide association studies. Not one particular gene, but a combination of genes together makes it very high index of suspicion. Again, going back to your multidisciplinary team, the team lead is a family doctor, someone who knows this family. So you can see how easy it is for someone who knows a family, who knows the child, to speed up the diagnostic process, to avoid saying there is pretend, or to avoid other directions that are not necessary, or take away from the quality of life of the child. So that's one. Number two, and very important, is care provision. Who is providing care? You have to have a standard way of doing things. For polymyositis, it's a chronic disease. It's very debilitating. It's hard to diagnose. So not only do you need someone who knows what we did last time so that we can do something next time, you also need someone who's going to support the family throughout the chronic disease. You have to remember that this child doesn't live or breathe only hospital and doctors. They are friends.
They have a life.
They have a life. They have a family. So you need to not only multidisciplinary around the baby and the child or the adults, you also have to be community.
Think outside and think about their social welfare and social well-being.
Correct.
Okay. Is it possible, or what is the likelihood that, like we've seen, it has shown up in this person, that it is going to be passed down, the genetic line?
Yes, it's very highly possible because it's a genetic susceptibility. So many genes appearing in the same person, they have a high risk of getting polymyositis. And this can be transferred or is actually seen within the same family. So with immune disorders, you can have one of them with polymyositis, another one with lupus, another one with eczema, but within the same family. Yeah. So even when we talked earlier on in another episode, when we were talking about pedigree, the pedigree is also very important, so that family doctor or the primary doctor understands that family. So he's able to say, that's how I know my high risk,
I'm at high risk of developing this.
Yes.
Okay. You've talked about the multidisciplinary approach to diagnosis. How would the treatment be like once somebody has been diagnosed with polymyositis?
So once we have the diagnostics done, we already have a plan of care. The primary care provider for most of the polymyositis should be a rheumatologist. Depending on the age, the children below 18 will be a pediatric rheumatologist. The adults will be in an adult rheumatology clinic, and then now they will be followed up. Because it also affects other organs, from time to time, there will be involvement maybe of a kidney specialist, a liver specialist, someone else who would look at the neurological area. The neurologists will be involved. So depending on what is going on, then we will have to take care of the patient the way they are. But the management has to be centered. It's very important that it is one doctor doing all this so that there's proper follow-up.
Like the team lead now.
Yes, the team lead who will now be able to say, let's say if it's a child and it's time for vaccines, send them for the right vaccines when they are not immunocompromised, or delay the vaccines until when they are better. And then when they are going to hospital, have a note. Most of my patients go around with a little piece of paper informing the team, because you can get sick anywhere, far away from your primary doctor, informing the team, yes, maybe Shannon looks like she's not able to walk, but it has nothing to do with her nerves. She's in a little bit of pain, control her pain. She's in a little bit of need in her crisis. This is what you need to do. Remember, she's going to have muscle breakdown. Therefore, there's going to need proper hydration so that the kidneys don't get jammed up. So there's that need to have that communication. And the parents, the care provider, the child themselves, they have to know what's going on and what needs to be done. So they are their best advocates. So when they go around to the different providers, they're able to communicate.
Okay. Are there any long-term complications from this disease?
Yeah, a lot of them are to do with the disease itself. The second part is to do with treatment of the disease itself. So let's start with the disease itself. The disease itself is going to cause you to break down your muscles. Your muscles are continuously inflamed. So the debris is going to be cleared by the liver
And the
and the
kidneys.
kidneys. So these two organs need to be protected. And how are you going to protect something that's already occurring innately within you? So that in itself, in the long term, may be a concern. Secondly is the treatment. Treatment, of course, is around the steroids. Steroid therapy in a growing child might curtail their growth. Yeah, steroids in of themselves make you volatile to other infectious disorders. So all these are side effects of treatment and other
Of the disease
complications
itself.
of the disease itself.
Okay. Is there a risk of, say, physical disability in any way because now the muscles are being affected?
Very high risk, especially when they cannot move, when the inflammation is at peak, because they can't move. And if you just sort of not give them physiotherapy and occupational therapy as they get off it, you might find a situation where the muscles also get to something called the atrophy. And that means they don't have the power to get back. So whenever they get into a crisis and they can't move, they always need to do passive exercises, even when they can't move. Passive exercises, no matter how painful they are very important for that child. Yes.
How important would be early or prompt diagnosis and early intervention in the management of this condition?
And everything, the earlier the better. It would be the best time if you could actually find them as even before she fell. If it would have been found even before she fell, would have been very good. So that now, apart from the understanding, you prepare for treatment and then you don't have all those community losses and social losses. There's something on treatment apart from steroids. There is a role for plasmapheresis. You see these antibodies that are attacking the muscles, you can actually clean them out, something akin to what we do in dialysis, but now for the plasma to just remove the autoantibodies that are fighting the muscles themselves. So there are very many treatment options that you can discuss with the family and see what is best, especially when it's a child who is growing.
Are they available locally here in Kenya, like, for example, the plasmapheresis you're talking about?
Yes, plasmapheresis is available. It's not the cheapest, but it is available. Yes.
Okay. Looking at the big picture on autoimmune diseases, autoimmune conditions, how common are they in Kenya, or is it that we hear them sporadically?
I think we hear them sporadically, but they are very common. My best friend had one, so you know. So I think they are very common. The thing is to remember that as doctors, we are different. So we have different clinical training. And as I said earlier, your primary doctor is your best doctor because they know you very intimately. And then they are able to bring in a lot of the expertise that you need. So when it comes to autoimmune disorders, there are a lot of people who are interested in the same, from allergologists, immunologists, rheumatologists, pathologists, hemato-oncologists, all of them looking at autoimmune disorders, geneticists, and everybody else. But they are not very few, but they are not being picked up early enough for us to do something and make a difference without alluding to other negative forces or pretense, or I don't know what else is said about this disorder.
Is there something we can do within our healthcare system as a country to improve early detection, proper diagnosis, and management?
I think the support of innovation, research, and technology should be improved. We have this knowledge, but it is widespread, not clustered in one space. And most countries, and even our own country, when you want to develop something, you have to first of all finance it and allow the scientists time to grow it. Then it becomes a common thing out there. So for me, something that needs to happen in the health system and as a whole is the support for innovation and technology and research. I know people talk about NACOSTI and KEMRI, But that's not enough. You need someone in the clinical arena. Allow the professors not to be in the books only, but also to be at the clinical, the implementation scientist, where we are trying to say what's in the books, what's in the scientific world has to be translated to the betterment of the patients, and offer that space to allow the Kenyans and everybody else who has a diagnosis that is not making sense access these people who are sitting together and actually working together, not by choice, but by design. So that now we're not saying about a disciplinary team because I have formed one, but it is already designed that if there is a concern, like I know about TB and HIV, when there's a concern about a patient, there's a team that is already designed to look. So why don't we have designs on these difficult disorders, rare disorders, where by design people are coming together to discuss the different cases, and all the health providers are aware that if you have a difficult case, if you have a question about diagnosis, you can go to this group of people and they can look into it.
Yeah. Okay. We've seen from Shannon's story that, they were door to door in hospital over a long period of time without getting a diagnosis, and the symptoms were unexplained. What message would you have for families that, have a child or even an adult with certain unexplained symptoms and nobody is giving them an answer, or nobody seems to know what's happening? What message would you have for them?
Keep asking. Push. Keep asking. You're the best doctor to your child. Keep on asking. We're in the information age. All this information is out there in the internet. Of course, not Wikipedia or Wikino, but you can actually find different people who know a lot of things. And in the global village, it's very easy to come across just typing in things in a search engine, and you'll be told, oh, that fits here or that fits there. And then now go not to any other person, but try to trust the locals to find out, to figure out and say, I went to the internet, I saw this fits into this. What do you think? What do you think? And then you actually arouse that inquisitive nature. Yes.
Okay. Thank you very much, Dr. Mutinda, for sitting with us and explaining about polymyositis. For people to keep knowing and asking, raising awareness about some of these things that they may not understand or have a clear view of what's happening to their bodies or to their children or to their family members. So we thank you very much for your time. And thank you for watching, I hope, or listening. I hope this episode has given you a clearer understanding of polymyositis and the challenges that families face. You have been watching and listening to Willow Lifeline Dialogues Code of Life series. If this series or show has touched your life, you can share it with your family, your friends and colleagues, and subscribe to Willow Health Media on our YouTube, Spotify, and all our social media platforms at Willow Health Media, where we keep on bringing you conversations and stories that bring science into everyday health decisions. Until next time, stay informed, stay empowered. I'm Dr. Mercy Korir.